Hi, everybody, and welcome to a Prasiska GI cancer-focused tumor board. My name is Sam Klepner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, and I'll go around as I see it on my screen. So I'll start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Hi, everyone. I'm Pritesh Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University in Atlanta.
Hi, I'm Marty Weiser. I'm a colorectal surgical oncologist at Memorial Sloan Kettering Cancer Center in New York.
Hi, I'm Al Benson, and I'm a GI medical oncologist at Northwestern University in Chicago.
This is a relatively young male with an invasive, moderately differentiated adeno of the gallbladder. And so pretty typical presentation. Patient comes in with right upper quadrant pain, otherwise perfectly healthy, really no significant past medical history or GI cancer family history. I think all of our institutions have seen cases quite similar to this. So patient has come in with recurrent abdominal pain. In January of 2020, they had an right upper quadrant ultrasound with a hyperechoic structure residing in the gallbladder fossa, thought to be abnormal gallbladder. There's a CT abdomen pelvis, which we'll get a snapshot of, and we don't have all the images, so I'll read some of the findings. That it's notable that the gallbladder does not appear to be completely filled with avascular enhancing soft tissue mass. There is some focal enhancement and some distension and edema along the fundus. And so this is thought to be perhaps infectious inflammatory, and the patient is referred for surgery. So I'll let Dr. Siegel comment on this single slice zoomed in area.
Well, we can see here the gallbladder is not distended, and then there's focal thickening. I think we're in the gallbladder fundus on both the anterior and the posterior aspect of the gallbladder wall. More gallbladder wall thickening on the posterior or the hepatic side. The differential here is going to include adenomyomatosis, which is sometimes tricky to differentiate from gallbladder cancer. One of the ways that we do try to discern the difference is on either high resolution ultrasound or MR. Look for those tiny little cystic areas that you could see in adenomyomatosis, which you won't see in a gallbladder cancer. And when you look at the anterior aspect of the gallbladder, in addition to some thickening, there's also a little bit of soft tissue that extends outside the gallbladder, which would make me more suspicious for a gallbladder cancer and less suspicious for a adenomyomatosis, because that's usually confined to the gallbladder wall.
Yeah, I think these ones are always tough and often come in through the emergency room very frequently. So here's a continuation of the oncologic history. So like many of our patients came in through the ED for this symptomatology. We saw the CT findings, and here's just to add some ultrasound findings demonstrating sludge and a thickened and edematous gallbladder wall, as was mentioned. The patient was taken for a laparoscopic cholecystectomy. The pathology is here. I'll read the highlights. It was an incidentally discovered invasive adenocarcinoma, moderately differentiated, measuring 1 centimeter with invasion into the perimuscular connective tissue. The tumor extended focally to the cystic duct margin and less than 1 millimeter from the hepatic cauterization margin. There was no evidence of serosal involvement, and the patient was pathologically staged pT2bNxMx. The immunohistochemical stains are shown here and consistent with a primary gallbladder cancer. So I'll start with Dr. Weiser in terms of thinking through this case of an incidentally resected gallbladder cancer. Do you think about oncologic surgeries? Is there things you'd want to do before consideration of that?
Well, of course, full staging will be important to look for metastatic disease, which is quite common. For localized disease, we do think aggressive surgery has benefit, and this includes removing the liver behind the gallbladder fossa, what we call segments 4A and part of 5. And with a positive cystic duct margin, you may have to do a bile duct resection and reconstruction. Again, this is a complex procedure that needs to be done at a center that's familiar with this, trying to clear that margin. Again, though, the risk of metastatic disease is quite high, and you'd want to rule that out first.
Yeah, completely agree. Let's say the metastatic staging is negative in a perfectly healthy 53-year-old male. Would your institutional practice be to consider a surgical curative intent salvage operation in this patient?
Absolutely, yes.
Yeah, I think everyone probably agrees with that. So, over the past few years, we've seen some debate about the role for adjuvant therapy in gallbladder cancers. So let's move on to this case, which will touch on some of those things. So there is some staging studies here. There's a CT scan that shows no evidence of metastatic disease, some incidental hypodensities in the liver. The patient, as Dr. Weiser predicted, presented for surgical discussion and underwent a curative intent right partial hepatectomy 4 and 5, exactly as was commented, a hilar lymph node dissection, as well as a bile duct resection and a hepatico-J with a Roux-en-Y reconstruction. The surgery was positive for residual adenocarcinoma, which was a small microscopic focus involving the periductal soft tissue, presumably near the margin, and one lymph node was positive for adenocarcinoma. So a month after surgery, a patient is hospitalized for an abscess, blood cultures with Klebsiella bacteremia, treated with IV antibiotics and CT drainage. Another month later, so now 2 months after curative surgery, the abscess drain is removed. And then I'll start with Dr. Benson in terms of thinking about adjuvant therapy. First, I'll just cover this. Well, let me go back from so we can talk through a little bit. So how do you think about adjuvant therapy in resected gallbladder cancer, and what has been your approach typically?
So probably the best evidence we have is the BILCAP trial, which included gallbladder patients as well as cholangiocarcinoma patients, which compared capecitabine versus observation, demonstrating a benefit for chemotherapy. So outside a clinical trial, we would speak with this patient about capecitabine adjuvant treatment for about 6 months.
Agree. I'll extend the question to both you and Dr. Patel. Given some SWOG data with gem-based therapy and incorporation of chemoradiation, are there situations where you think about involving radiation or that type of a chemotherapy approach? Maybe I'll start with Dr. Patel to speak to the role for adjuvant radiation.
Yeah, in our practice, this is a common presentation, and similar to what was done in that SWOG study, I think optimal systemic therapy first. I think certainly our priority, and then with restaging. But for a locally advanced gallbladder cancer or cholangiocarcinoma, we do often meet patients in our radiation centers to discuss, again, the merits of adjuvant chemoradiation in this disease. I'm fortunate to also work at our proton center, so this is one of the indications where we may opt to use a proton treatment. Similar to other types of adjuvant therapy in the abdomen, these can be, again, larger areas of treatment. And so some of that toxicity that you might see with larger fields, I think we do a better job with proton therapy in some cases if it's available. So again, optimal systemic therapy is our priority, but thereafter, we often do have a conversation about adjuvant chemoradiation as well.
Yeah, I agree. A common topic in our institution as well. And Dr. Benson, given the relatively young age of this patient, would this be someone you would think about genetic testing or MMR testing from the resection?
Yeah, we would certainly test for MSI. It doesn't appear he has any significant family history, so perhaps not initially consider genetic counseling unless by chance this was MSI. We too would discuss this case at our multidisciplinary conference. The patient would probably be presented twice after the initial surgery and then after the second surgery for consideration of approaches.
And just for our audience, I'll ask Dr. Weiser, can you comment on the typical, say, post-operative complications for this type of operation, and only because this patient had an abscess in particular?
Yeah, some of it may depend on the timing of the second operation after, a previous one, infected field. It's not uncommon. I think the other big issue would be, leaks from the hepatico-jejunostomy that can be quite problematic. And commenting on radiation, of course, we'd have to think about that when we incorporate the radiation fields, which would complicate matters a little bit. And I think for the most part, capecitabine is not overly immunosuppressive. So we're lucky in this situation that you probably started pretty quickly after resolution of the infection.
Yeah, it's you're predicting the future because it sounds like this is exactly what happened. So patient was initiated on adjuvant capecitabine, did have some delays in dose reductions due to a hospital admission for sepsis and drug toxicity, not specified exactly what that was. Sounds like maybe potentially cytopenias. And then a month later a month after starting adjuvant capecitabine was admitted for this sepsis and underwent a CT brain that was negative. And then 3 months later, presumably the patient had resumed. They underwent a CT scan, which had a ill-defined area of an intrahepatic hypodensity adjacent to the gallbladder, which was decreased, presumably the abscess. And the previously seen hypodensity in the right hepatic lobe was not clearly seen. There was some thickening along the peritoneum near the inferior tip of the liver, which was of unclear significance. And patient sounds like had another episode of recurrent fever and chills without clear imaging evidence of abscess, and cycle 7 was held. And then, as Dr. Benson suggested, there was, the patient completed a total of 8 cycles and was currently on surveillance. So now the patient has completed an adjuvant course, and the question is, what is your surveillance strategy? So I'll ask Dr. Siegel to you're welcome to comment on the surveillance strategy, but does these imaging findings on the September scan inform the type of scans that you might want to see on surveillance? Would you want CT in addition to other types of scans to correlate and help resolve some of these questionable or equivocal findings?
I think some of this depends upon how well the patient's feeling. In general, I tend to prefer MR because I think the diffusion imaging can be very helpful. But patients really have to be able to hold still for a lot of the sequences on an MR. So I would say, all things being equal, I would prefer to do MR. Sometimes in terms of access, it's easier for patients to just get a CT. So oftentimes what patients end up is some sort of an alternating approach of CT and MR for follow-up surveillance. But I would say, I probably prefer the MR. I think I get more information, more series over time, and I get more information in terms of the diffusion and the T2 weighting images. So I tend to like it a little better.
Yeah, I think that's very helpful. And I'll ask Dr. Benson, in terms of frequency of imaging in someone who's completed adjuvant therapy, how do you think about what is your recommended general frequency, and do you do anything else in addition to imaging? Do you follow CA19-9, for example, in these patients?
Yes, we generally follow guidelines on this. You know, one of the problems with surveillance strategy is they're just not tested in terms of clinical trials, so we don't have an optimal strategy. However, when you think about surveillance, you need to think about what is the risk of recurrence and the interval of greatest risk. And in this disease, certainly the greatest risk of recurrence is within the first couple of years. So we generally see patients initially, at least for the first 2 years, every 3 months. We do get imaging every 3 to 6 months, and we also get CA19-9 and CEA. And I think this strategy is consistent with guidelines based on what we think might be optimal when you take into account the risk of recurrence.
And in total, I mean, I know you have chaired the guidelines committees for, for this anatomic tumor type. How long do you follow these patients overall, assuming things are going well?
Generally, for 5 years, although decreasing the imaging over time. I think a lot of patients are more comfortable keeping that link that an oncologist is watching over them. But we do explain to people the interval of greatest risk, but you know, every now and then people recur a little later than that.
Yeah, I agree. We tend to sometimes see people yearly, even after the 5 years, just to say hello, and it becomes a nice clinic visit when you don't have any cancer to discuss.
Yes, for sure. And I think patients do like that for the most part. It is reassuring and to maintain the relationship.